right. Another quick housekeeping point, there will be a moment or a couple slides when I'll share some data from the National Center for Child Traumatic Stress Network that will probably not be in the materials that you receive as a final handout. If you have questions or would like to see this data, please contact Lisa, myself, or Ernestine Briggs King, and we can figure out a way of how to get you to some of the data. Unfortunately, what I'm sharing today, we just got clearance at the end of the workday yesterday to share, so we haven't had a chance to publish this or to put it on our national network outlets. So, why preventing child sexual abuse in North Carolina matters? I'm going to walk us through very quickly just 4 key points. First of all, I'm going to talk about some of the recent brain science that was shared just as of last week at the national meeting for the American Academy for Child and Adolescent Psychiatry. Then I'll share some data that's specific to North Carolina for child sexual abuse and the systems that are impacted. And finally, I'll end with a very quick discussion of some prevention targets that we can consider as next steps. So, we are all very aware, anecdotally, clinically, professionally, that there are 3 main, does this work? Do I have a laser? Yeah. That trauma in and of itself, be it child sexual abuse or other types of ACEs, that they're biologically indeterminate. And what that means is that they are different outcomes for different people. And essentially we have 3 different types of phenotypes. One is for individuals who are not exposed at all, and so they're considered to be typically developing individuals. And then we have individuals who are exposed to some kind of trauma, be it child sexual abuse or others, who go on to have what we would call a resilient profile. These individuals have had these experiences, but they appear to be seemingly unaffected. And then we have the 3rd type of phenotype, in which individuals do become disrupted and is following the trauma and also probably a product of other experiences that they're having in their broader context. So this is the baseline that where science has been for the past 10 years or so, just trying to understand the differences between these 3 groups and similarities. But with the recent neurobiological science, we are starting to understand, what does this mean? How is the brain actually bringing about these changes that relate to these differences in behavioral outcomes that we can also see in clinic and even diagnose as clinical conditions? And I'm not going to quiz you or expect for you to remember any of this information about the figure that's shown here, but all I wanted to make was a statement that what we know now about brain development is that child sexual abuse has a very distinctive profile and impact on the brain and how it develops and how it communicates to the rest of the body and how it continues to have plasticity over the life course. In particular, work by Dr. Martin Teicher, who is the leading researcher in this area for neuroimaging. His work shows that regions of the brain actually impacted by child sexual abuse are related to sensory systems related to our visual pathways. Essentially, individuals who have experienced child sexual abuse, they actually have a different way of reading and recognizing emotions on faces. In addition to that, their touch pathways have been affected that are specific to the genitalia area. So what Dr. Teicher's lab proposes is that these desensitizations are actually protective factors to allow the individual to have evolutionary fitness so that they're more inclined to continue with reproduction in late adolescence and early adulthood. Basically, because there's a protective layer for the experience or trauma that has occurred, that they can not have an adverse reaction to being touched or to seeing other intense emotions and things. Some additional work that's happening in his lab goes on to show by Dr. Ohashi that this protectiveness, although it's really good in adolescence and maybe even early adulthood, at some point in development, usually after the age of 18, there's a wearing effect where it wears off. And these individuals become more susceptible to issues related to mental health, and they just start to weather. They start to become more vulnerable and just fray at the edges in a way that was not apparent in adolescence. And more so, there's additional work by Dr. Zhu, also in Teicher's lab, that shows that depending on when the abuse occurs, that these individuals pre-puberty, we can actually see the brain fiber networks and how they're correlated with outcomes related to oppositional defiant disorder, conduct disorder, and substance abuse if the maltreatment occurs before puberty. And after puberty, these brain networks that are associated with anxiety and depression when child sexual abuse happens later in life, after the point of puberty. And in addition to that, there are tons of corroborating studies that show different effects. And I'm just going to run through a quick list for this, and I'm sorry and I apologize to use some of these really technical science terms. You're happy to write it down and I can send you the exact references, but I just find it fascinating to know that so some of the changes that we see in the amygdala, in the size of the hippocampus, and the anterior cingulate, that they all have been correlated with PTSD, as well as factors that lead to thinning of the prefrontal cortex. Conversely, a thickening of the prefrontal cortex is correlated with depersonalization, derealization, and identity alteration. I mean, if you step back and you think about that for a minute, that how protective it is for these individuals to be able to deny exposure, to forget, and even to disassociate their identity from their exposure, helps them to go on and live a somewhat normal functioning life. That these are absolutely essential changes that have to occur, and the brain does that and understands how important that is for survival. Moreover, there are additional studies that go on to show that changes in the right hemisphere alone in terms of size is associated with your denying the ability to fight or flight in the presence of abuse, sexual abuse specifically. And so you wonder, like, why would that be a healthy response? And so I just challenge you to think about being a child, because the average age of a victim of child sexual abuse is 10 years of age. These individuals are highly dependent on the adults and the caregivers around them. They are not in a position to fight, be it a peer or an adult who is touching them, and they're not necessarily in a position to run away. Where are they going to go? How is that going to help them? And in terms of an evolutionary standpoint, that works against everything in which we're designed to do, which is to survive so that we can procreate. And just to make it very plain, I know that is an unpleasant way of thinking about human nature and how we interact, but ultimately we do have these biological processes within us that insist that we survive despite the worst. However, there is this weathering effect whereby adults are less protected and begin to fray, as I mentioned before. And there's even studies that look at cortisol in terms, that look at cortisol, and they see a blunted response in adolescent, but an elevated and sustained response when subsequent exposures to ACEs occur over the life course. And so what does this mean? Why is there more of an effect in later adulthood for exposures that happen when you're a child? And so there's a prevailing theory that's really popular right now that's proposed by Dr. McCrory and Convening, which is the latent vulnerability theory. And basically what it suggests is that there are gene and environmental interactions that could infer vulnerability or even resilience to individuals over time based on their social and environmental stressors as well as their genetic makeup. So this is one of the key links in explaining how are twins with the exact same chromosomal genetic makeup and familial environment can be totally different behaviorally. And it's because of these methylation patterns and other epigenetic processes that are happening along the genome. So essentially, and I'm going to get into a little bit more detail about exactly what those processes are, but the thought is that if an individual has a genetic vulnerability, and if they're placed in an environment that's not supportive, then they are more likely to have that third phenotype, where they are disrupted based on the initial exposure. as compared to another individual who might have a resilient genetic makeup and who could be in a supportive environment and therefore present as if they have no symptomatology related to the exposure. And these have, and there's lots of research now that's looking at the threat processing system as well as the memory processing system and the reward processing systems that show that the brain is actually functioning very differently based on the environment of individuals as well as their genetic makeup. And interestingly, Dr. Tetra's lab has gone on to show that resilient individuals, because the thought might be that, well, perhaps resilient people, their brains are just different from those who have been exposed and are disrupted. But that is not what the science shows. If you look at the imaging for these individuals, they have the exact same assaults and changes and disruptions and maladaptive qualities in their brain structure, the size, the functioning, the brain fiber network systems as those who are disrupted. But they still have the same symptomatology as individuals who have never been exposed, especially as it relates to outcomes for depression, anxiety, somatic pain, and anger and hostility, and risk for substance abuse. So what is happening? A key thought is the social support. Because as Lisa mentioned early, nurture is just as important for the human design in our development as well as risk factors that we're exposed to. And it can not only make an individual resilient, but there is research that is coming out, hopefully within the next year, that was shared at the conference, that shows that even individuals who have already been exposed and are disrupted, that it helps to regulate them and shift their behavioral outcomes to look very similar to resilient individuals. And that is really promising and hopeful. And it's a key reason why prevention has to happen, not just for perpetrators, but also on the other side for victims. Because we know that, because that prevention gives us hope that not only are people who've already been exposed and are already in a treatment process, that perhaps we wouldn't even have to deal with any of the brain structures that we know could become vulnerable again and unwind over time for these individuals. So what? And I have to say this really good, and I'm going to say it emphatically. So what? Because that is how Jane Costello, my mentor of the Great Smoky Mountain Studies, would say about pretty much any scientific article that she would read. Because what she thought was more important was, what does this mean for individuals and societies across a life course? It is very easy to know what's happening in the here and now. It makes complete sense. We don't need to spend millions of dollars on a fancy study to say, hey, if you have a really bad exposure, you're going to have a really bad life or something. You're not going to be happy in life. But she really challenged the scientific literature to dig deeper, to really understand what's happening to these individuals developmentally. And she had the great opportunity to lead the Great Smoky Mountain Study, which has nearly 1,500 individuals, and it's right here in North Carolina. It is a high-risk sample that was developed to detect mental health disorders, and they started at the age of 9 in the early 90s when individuals had not been exposed to any really major life issues. These individuals, their main exposure was being in a rural setting and being from a low-income community. If any of you have ever been out towards the western part of North Carolina where this study is, you'll know that it's beautiful. It's also fairly remote, and it includes the Cherokee reservation that's in the western part of the states in the mountainous region. But it also has Asheville. And so we have a nice counterbalance there of being able to look at some of these socioeconomic differences for individuals and to have a diverse sample set. So 50% of this cohort who we've been following since they were 9 years of age and who are currently 35, we've been able to look into see how mental health conditions have emerged over time. How do they correlate it with race and ethnicity, socioeconomic status, and also what does this mean in terms of the intersectionality for some of these ACEs exposures that Lisa shared with us earlier? And one of the things that's relevant for our talk today is to dig deeper into this child sexual abuse data. And for all of the individuals who've been surveyed and who we followed, we have over 11,000 total assessments. And of those, nearly 11% had child sexual abuse exposure. In subsequent, well, not subsequent, but I guess as a co-occurrence, these individuals, we already have the risk factors that they were exposed to in childhood between the ages of 9 to 16. They had a co-occurrence of family dysfunction, an increased odds for low family SES, as well as depressive symptoms, oppositional defiant disorder, and conduct disorder. And this information is really relevant because we wanted to know, well, what would happen to these individuals as they age? Because unfortunately, as advocates and as stakeholders and as policymakers, at the end of the day, what we really want in society, or one of the main focus of our government, is how do we increase economic productivity? And what we learned that in adulthood, for these individuals who have had this childhood sexual abuse exposure, is that they are more than twice as likely to have depressive diagnoses. And this leads to a low economic productivity, a loss of economic productivity. In fact, these individuals are 70% less financially stable compared to their peers. And if you think about that in terms of dollars, I mean, it is huge. Those are numbers that we never even get to calculate truly when we talk about the real cost of child sexual abuse in North Carolina. So given that child sexual abuse in particular is one of the most potent exposures of trauma, and it's reported that 20 to 40% of all psychiatric patients report child sexual abuse at some point in their history. We think in Great Smoky Mountains that it's imperative for us to dig deeper and really understand this connection with the biology and with the mind. So we've started an epigenetic study where we've taken biological samples where we've banked them since they were 9 years of age. Annually, we have a sample at 9, 10, 11, 12, 13, 14, 15, and 16 years of age, and again at 19 years of age, 21 years of age, 25 years of age, and 30 years of age. And we're looking at this genetic genomic profile of epigenetic markers to really understand this relationship between ACEs and physical mental health outcomes. So this is one of the first studies, is much intensive than even ABCD, if any of you are familiar with this huge investment by the NIH, but this study will allow us to look at these changes in methylation profiles over time, pre and post exposure, and also the intersectionality of a lot of these demographic factors that we know are important. So, moving along. The next, so what? So we know that this is a problem. We know this is related with really negative mental health outcomes, and we know that it persists across the life course. Well, here in North Carolina, there is a bigger question that we want to know. What does it mean for our systems? What are the cost implications for society beyond just the individual? And I think we have, well, not I think, I know, we have an amazing resource through the Child Traumatic Stress Network to look at some of the rates of reported child sexual abuse and the systems that these youth are involved in. I do want to share a few caveats with you about the data set, just so that you can understand the numbers that I'm presenting here today. So first of all, some of the totals that I provide in terms of the sample size are larger than the ones that Lisa shared previously, and it's because the network expands each year. And so there's more data coming in, new clients at each of these centers. And the fact that this is a patient-centered or a place where people seek treatment who have been exposed to trauma, the data set is not representative. So when you see the word North Carolina here, this is not representative of the general population of North Carolinians or Kakalackians, however you identify. That's not what's being shown here. These are individuals who've gone to a clinic for treatment specific to trauma. And then for the NCTSN, this is not nationally representative data. It represents about 43 different states that have child trauma centers, institutes, organizations within them, embedded inside. And they're sharing these results based on a template that has been shared across the network, so that they're collecting all the same measures on trauma, all the same measures on systems that are involved. And that's just a sliver of the data that's collected. And I feel really honored to even be able to share this with you today. the average age of the individuals in this large network who have been exposed to child sexual abuse, it's about 10 years of age. So that's just really, I don't know, I'm a mom, and it's just, and my kids are already past this 10-year mark, but I just remember how precious and yummy and a bit impish they were at 10, but the fact that some of these kids are dealing with issues that we as adults cannot even fathom for ourselves. And not only are these children really young, but on average, they have already experienced 3.7 traumas out of a list of the 20 that Lisa shared with us earlier today. I just think that this should take a moment of silence just to really process that. And then when we go a step further to try to understand, well, what does it look like for those individuals who've had child sexual abuse? Their number of traumas increased to 4.9 on average. That's a lot. I mean, and that's specific to North Carolina. And so this data shows that even in terms of general exposure to child sexual abuse, throughout the national network, we have 25%. And in the state of North Carolina, where we actually have to have a meeting to discuss why prevention is important, our rates are at 32%. That's completely unacceptable. And then when we go further to try to understand what are the social systems that are impacted for these individuals, there's data within the NCTSN that shows when these children come in for their initial clinical assessment, they're asked, in the past 30 days, what services have you been engaged in? And what we see is that these youth, unrelated to the therapies that they're going to need for their child sexual abuse experience or exposure, that these clients are already involved in child welfare, they're already involved in our healthcare system, they're already involved in our schools, and also the juvenile justice system. So the asterisks that you see on the chart, they represent differences, statistically significant differences between the national network and North Carolina. And what we observe here is that when it comes to healthcare, the healthcare system, that North Carolina has a much higher rate of incidents, individuals presenting with child sexual abuse in our emergency rooms. So essentially, because, well, we can talk about the why in just a moment, but let me continue to talk you through this figure so that you can be a little bit better oriented, and maybe you'll have some questions for me later. In terms of the child welfare system, we see that North Carolina is more than 50% of the youth who have child sexual abuse exposure, that they are also engaged in a child welfare system. And that is significantly more than the other trauma sites across the nation. And not surprisingly, because they're involved in child welfare system, they're also more likely, not more likely, but significantly more, they're significantly more in foster home care. And then in terms of the school systems, we have a kind of a reverse impact where there are less supports that are provided in the schools here in North Carolina compared to the national network for school clinicians, be it counselors, social workers, psychologists. And then in terms of the intervention programs, where there are classes or extracurricular activities or therapies that are specific to this population, we have less of those type of services, or these people are not accessing them. And then finally, I guess the one glimmer of light or hope in this story when we're comparing North Carolina to the rest of the network is that we don't have any cases that are involved in the juvenile detention centers or jails, but we have less involvement for children who've been exposed to child sexual abuse in the probation officers and court officials. I just find this data really staggering, and I think it raises a lot of points for discussion. So please feel free to ask me as many questions as you like. I've printed out some more detailed specifics to really dive into the data more later if you would like. But just please remember that this slide in particular and the previous one, they cannot be shared or distributed beyond this audience without permission. So how do we change this? How do we turn this around? Where does policy come into place? Where does advocacy and stakeholders, what are some of the things that we can do? Well, as a start, we already know that there are evidence-based preventive interventions that work. There is data out there, and this is kind of like everybody's saying, do home visiting. It works, people, across all socioeconomic levels. This is a no-brainer. There is parenting education and support. When people know how to parent better, they do better. And I just think that's important. It shouldn't be something that we decide who needs it and who doesn't need it. We all need it. I remember personally when I brought my baby home, my first child, and I had this really thick book, and it said 274 ways to play with your baby. And I had it on the, my end table, and my grandmother came to visit me about 3 weeks after I had the baby, and she said, "What do you need this book for?" And I said, "Are you kidding me? This thing just stares at me all day. Like, I run out of all the tricks I have in 5 minutes." And I was just really fortunate to have access to resources and a drive to want to know more and how to parent. But I think about younger parents, parents who are stressed, parents who have limited resources, parents who are literally passing their baby along from one individual to the next up to 5 different times in a day for some low-income part-time workers. And just the type of supports that they need to be the type of parent that they actually have the potential to be. And then we know that early start programs, be it childcare or pre-K or just after-school programs, they make a difference. They drive down rates. These are wonderful prevention practices. And then in terms of the policy levers, we are so fortunate here in North Carolina to actually be able to make a difference as we have these really large and sweeping legislations that are coming down the pipeline. Specifically, there's Family First Act for the Child Welfare Program that's going to be rolling out in 2020. And if you're not familiar with it, this is a wonderful opportunity to really address this system in which we know there are lots of victims and possibly even perpetrators who are part of this program as is. It's a great place where we can ensure that individuals are really, not just the individuals, but the families that they'll be a part of and the systems, that they're getting the support that they really need. The University of California is serving as a clearinghouse for resources on how different strategies can be implemented in child welfare systems to really make a difference and benefit individuals and communities. So if you want more resources, it's worth taking a look, especially because we have a unique we have a unique challenge. Nope, I'm tight. Lisa, could you pass me some tea? We have a unique challenge here in North Carolina because many of the states, in terms of their child welfare systems, are dispersing the funding and the programs on a state level, but not in North Carolina. I don't know what it is about North Carolina. Maybe because we go from the mountains to the sea, but we always seem to be doing things a little bit differently. But we're gonna take a county approach, which means there are 100 different ways in which this funding and programs can roll out over the next years. So if you wanna get engaged, if you wanna be advocating for prevention, this is a great way. You have 100 choices of where you want to start in North Carolina. Another great legislation is the Medicaid reform, transformation, call it what you may, but a real upside of it is that they will include integrative behavioral health as a model of care for reimbursement. That sounds really boring to this audience, possibly, but not if you're a clinician. What it means is that either a primary care person can pull somebody over from behavioral science lab or a psychiatrist, psychologist, social worker to not only address issues that are specific to that child, but maybe they see a sibling might need to talk to somebody, or maybe even a parent. And now they have a way to bill for that. They have a way to identify and they have a way to provide treatment that's reimbursable for them. And that makes a huge difference for physicians who they don't necessarily have the autonomy to make the change that they want to see happen in the clinic settings because a lot of times their hands are tied based on their insurers. But this gives them a little bit more flexibility to consider these mental health factors. And in the way that this program is going to be rolled out is apparently in North Carolina. Again, there's not just going to be at like a state level, but they've broken the state up into 6 different regions. And so in each of those regions have anywhere from 1, I think, to 3 or 4 different providers for the Medicaid program. And so there are different ways that we can talk and learn more about what are the action plans, who's going to be covered, why and how, and for how much and how long. In particular, I think there's a key need to really lobby and educate and advocate for individuals who are part of the child welfare system or juvenile justice, so that they not only have insurance that's covered up to the age of 21, but expanded up to 25, knowing what we know now about the plasticity of brain development, and that the brain doesn't really stop developing until that age, and that many of these individuals, based on their earlier exposures in childhood, that's when they're going to need this care. That's when they're going to need the resources to go see specialists, because they could start to feel a bit frayed and weathered later in their 20s. And then finally, as always, there's state legislation. I know currently we have some bills that I've been working with Carla and others around survivors. Continue to push, continue to advocate and educate for these things. And then finally, in my closing remarks, there is community workforce investment. Community and workforce investment. We all know what are the predictors that create breeding grounds for child sexual abuse. And typically, some co-occurring factors are related to the economics of that community. It's simple, you know? I mean, what the problem is, we've already identified it. I think there's been a gazillion papers written about it. So let's actively work on promoting human and capital investment. And also just in terms of the trainings and the professional awareness that needs to be raised about risk factors, so that individuals can start to provide support for families who may be at greater risk of abusing or having their children exposed. And I know there's always a challenge of having required trainings. An alternative to that discussion is provide incentivized trainings. We have so many examples and models of how those types of incentivized trainings really make a difference, in that employees in professional settings, be they clinicians, teachers, child care providers, or even foster parents, that they will elect to do more if they understand the benefit of it for themselves. And so with that, I just want to thank you all for taking the time to listen. And I think we're going to open the floor up for some questions. And I'm going to... Could you grab that blue folder, just in case somebody asks me something really specific about data?
Sure. Questions? Thank you, Sherika. That was wonderful.
Child sexual abuse. What you're asking, okay, because there's some slight definitions. So we have measured child sexual abuse in terms of, did this happen during childhood by a peer or caregiver for the perpetrator, which is different and distinct from what we would call sexual assault in childhood, which happens from individuals outside of the home environment. And this is measuring 10.9% is child abuse and not including sexual assault. Oh, and I guess you should... And that statement was in reference to a question about the Great Smoky Mountain and whether or not child sexual abuse included the home environment or outside of the home.
That was my question. I just wanted to see if y'all could repeat the question so that we could all hear them.
Okay.
Sorry about that.
That's okay. You did great.
Okay. Oh, one more. Okay.
I have a question about, you're talking about the synergy of how the ACEs work together and you combine them, they have a higher negative effect. Loss of a parent was one. Does that mean the same if the parent was the abuser?
Oh, no, not in that case. Loss of a parent usually means if it's bereaved, meaning the parent has passed away, or it could be separated, like at the border, or maybe in, having been removed. No, that's considered separate. Okay, I'm going to turn it over to Sharon.